Good morning, everyone, and welcome to a special virtual summit on culture change in long-term care in Quebec. The event is hosted by Recreotherapy and Seniors Action Quebec, and my name is Michelle Holliday. I have the honor of being your host and MC for the next 2 hours, as well as for the optional small group discussions that will follow. And I can tell you that it was easy to say yes to the invitation to play this role. For many years, I watched my mother care for her parents through the end of their lives. And then I saw her move into professional caregiving, bringing deep kindness and also special skill. And I'm very aware that at some point it will be my turn to navigate these systems with her and on her behalf. So this feels like a very personally relevant event. And I can also tell you that my mother is one of the people participating in this call today, so that feels extra special. My role this morning is to guide the flow of the agenda, to introduce our speakers, to receive your written questions and comments along the way, and to facilitate the panel discussion. My role is also to help frame the event, to make it clear why we've organized such an online gathering, where we hope to go from here, and what role you might play. So I'd like to take a few minutes now to set the scene and to help us arrive in clear shared purpose before we hear from our speakers. Culture change in long-term care has been a necessary conversation for a long time. But this time, this moment in history feels different. And I wonder if you noticed that too. The pandemic has done several things to create fertile soil for a new, reimagined vision of caring for our elders. First, it revealed deep structural problems with how long-term care is currently set up. And the result of these problems was tragedy, with thousands dying and with residents, caregivers, and staff all suffering along the way. The pandemic also forced all of us across society to pause and reflect on what really matters. And for many of us, we found that what matters is family and caring relationships and living more mindfully. More generally, the pandemic also shook up assumptions about how we have to structure and live our lives. Maybe we actually can work from home, and so maybe it would be possible to care for an aging parent there. Or maybe after months of being cooped up with family, we learned that we're actually not cut out for that. Maybe we don't have to work as much or spend as much or earn as much. Maybe we can slow down and get to know our neighbors. And maybe we can help each other to get through difficult times. For all of us and in different ways, the pandemic shook up our assumptions and habits and opened the door to new possibilities. And all of this has created that fertile soil for something new to emerge, something rooted in profound culture change, both within our long-term care institutions and across society. So that's the context that brings us together. And just to be clear about our expectations, we're not going to come up with that whole vision of profound change in this 1 2-hour session today. This is an incredibly complex topic. And today is a first step in an ongoing conversation and exploration. But from what we discover today, our intention is to create a report and a set of recommendations that we will deliver to the provincial government. So we won't get to everything today, but we will get to something important and impactful. And if I can continue with my metaphor of fertile soil for profound change, the 3 expert presentations we're going to hear are like some of the first sprouts popping up from the ground. They're indications of what's needed, what's possible, and what's coming if all goes well. And just as important are your perspectives, which we're eager to include in the report. There are more than 250 people who registered for this call, and that alone is a message to the provincial government. And I also think it would be helpful to know how representative we are as a group of the whole ecosystem of long-term care. So I'd like to ask you to do something right now. We're going to bring up on the screen a quick and simple poll. to find out who's here. And it'll take just 30 seconds to answer this one question. And the question is, what group do you most affiliate with? Do you see yourself most as an older adult or an informal caregiver, a healthcare or social service professional or administrator, an academic or researcher, or a concerned citizen? And unfortunately, the technology supports only 5 choices. and you may not find yourself here. Oh, it's 6, okay. Or you may feel that you fit into more than one category, but choose the one that was most at play in your choice to join this call. And let's see. Wonderful. And you can see the results coming in. Thank you. A few more seconds to get our answers in. All right. Wonderful. Thank you. So you can see that we have a beautiful representation across all of those categories with a social service professionals and administrators, but wonderful representation across all of them. Thank you very much. That's fabulous. All right, so when you registered, we asked all of you 2 questions, and one was about the most pressing challenges in long-term care. So I'd like to share with you the top-level results so we can weave that into the context of our time together. So do we have that on the screen? It's a bar chart. There we go. That's the one. All right. So as you can see, the top 3 challenges you all named are staffing issues, unmet personal and interpersonal needs, things like boredom and a lack of belonging, and lack of personal choice and control. And from there, the next 3 challenges include a sterile and rigid environment within the long-term care facilities, a lack of national standards and protocols, and lack of support and involvement of families, support for the families and involvement of them. So these are the things that you were most concerned about. The second question we asked, as you all registered, was about your hopes and dreams for long-term care. And in my soil metaphor, I think of these as the little markers, little signs we put in our gardens where we've planted some seeds. And those signs help us imagine what's going to come if only we apply a little care and keep the faith in our vision of the future. So from those dreams of yours, those markers in the garden, what we heard most of all was the desire for a complete reimagining of the system. We heard a call to challenge the status quo, to move beyond a one-size-fits-all approach, and to make Quebec a model to inspire the world, where long-term care is a place we can be proud to live and to work. In particular, we heard the desire for more support for people living at home, and for those who can't, a more home-like feeling within the long-term care centers. We heard the call for more opportunities for recreation, meaning, purpose, joy, dignity, and choice. People wanted more caregiver and family involvement and support, as well as integration into the community. And there, one comment really jumped out. Here's what the comment said. In the 1950s, we deinstitutionalized people with disabilities. Now it's time to deinstitutionalize the elderly. It's powerful. So across all the responses, the most common wish was for kindness and compassion and respect to be at the core, and for long-term care to focus on quality of life, not simply postponing or awaiting death. And as you can see in this image, this word cloud, we created an image with all the main words that appeared across all the responses. So the more often a word appeared, the bigger it is in the image. And I love that it came out looking like a heart somehow. And across all of these dreams, a vision of the future is starting to come into view. And now, today, the intention is to put these many dreams of yours together with the insights we hear from our featured speakers, and also to weave in the comments and questions that arise throughout the morning. And from all of that, a report and a set of recommendations will be submitted to the provincial government. And we'll share that report with all of you as well. So please know that your presence and your contributions are important. And I thank you for taking the time to be part of this conversation. I also want to thank the event planning committee and the multiple collaborators, including vital partnership with Concordia University's Shift Center for Social Transformation. We wouldn't be here without this generous support from many. And I want to thank Sarah Hepner-Waldston, who is our graphic recorder today. She'll be drawing our conversation and the speaker presentations as they happen. It's quite an amazing talent and will be wonderful to include in our report. So can we just say hello to Sarah? And
sorry, good morning, everyone. I'm thrilled to be here with you. I'll be listening to what's going on and turn that in a picture to really help you tell the story and have something to share as we move forward to try and create the change that we're looking for. Thank you so much for including me.
Wonderful. Thank you, Sarah. And I have two more acknowledgements to offer. And for these, I wonder if you would be willing to take a few deep breaths with me. Partly because it just feels good to take a deep breath and it helps us listen and pay attention, but also because it seems appropriate to pause and acknowledge those whose recent suffering prompted us to come together today. So my invitation is to breathe in gratitude to the many frontline workers in long-term care facilities and hospitals who bravely dealt with the crisis these past months, even at great personal risk and sacrifice, and including some who are with us on this call. And then let's breathe out comfort and condolence to the thousands of families who lost loved ones during this crisis. Breathing in gratitude and breathing out comfort and condolence. And finally, I invite you to put your feet flat on the floor and feel its solidity and support in acknowledgement that we are gathered to reimagine long-term care in this place that we call Quebec, on this land that holds us together and whose original and continuing stewards are the Mohawk people who have much to teach us about what it means to have a culture that honors its elders. Again, taking a deep breath, feeling your feet on the ground, feeling our connection to this land that holds us together and that carries both history and present day lessons and opportunities. Thank you for that. So let's begin. We'll start with a brief welcome video from the Federal Minister for Seniors. Then we'll hear from our three speakers, and they'll answer a few of your questions at the end of each presentation, if time permits. Next, I'll facilitate a panel discussion among the speakers, again, drawing on questions that you've shared. We'll check in with Sarah and her drawing, and then we'll close with a brief recorded message from the Quebec Minister of Seniors. And then after a short break, you are all welcome to join us for the optional small group discussions, and we'll provide a link to that again at the end. So let's hear now from the Honorable Deb Schultz, Federal Minister of Seniors, who also happens to be very involved, she says, in her mother's care.
Hello everyone, bonjour à tous. I'm Deb Schultz, Canada's Minister of Seniors. I'd like to thank Seniors Action Quebec and Recreotherapy for bringing everyone together today to talk about this important issue. and I'd like to thank you all for joining the discussion. I'm looking forward to the outcomes of today's virtual summit. We need to do a better job of taking care of our elders in long-term care facilities in Quebec and right across the country. There are many excellent long-term care facilities, and there are others that are not doing as well. We need to make sure that we're improving the standards of care and the support for Canadians as they age and need more help. While the federal government does not regulate long-term care homes in Canada, we'll be there to support provinces and territories as they deal with the impacts of the pandemic and we move forward. As we gradually restart our economy, we're acting with the provinces and territories to strengthen long-term care residences across the country, because we will work to ensure that tragedies that occurred don't happen again. The Safe Restart Agreement invests $740 million for measures to control and prevent infections for long-term care homes and other vulnerable populations. We're investing billions to purchase personal protective equipment for health workers, including long-term care workers. And a new contingency reserve will ensure PPE is available to those caring for Canadians. And the new COVID-19 Resilience Infrastructure Stream lets the federal funding be used to upgrade long-term care homes, making them more resilient to keep seniors safe. Canadian seniors can always count on our government to listen to their needs and to work hard to deliver for them. Stay healthy, everyone, and have a productive summit. Merci.
All right. Now it's time to hear from our expert speakers. And I want to offer one last bit of framing to make sure it's clear why we chose these speakers and how they fit together. Otherwise, I find it can be overwhelming to hear all these details about all the changes that are needed and not be clear about how they fit together. So first, we'll hear from Dr. Pat Armstrong about the structure of long-term care, how work gets done, who does the work, and who pays for it. Then we'll hear from Barb Sutcliffe about the personal and interpersonal experience of giving and receiving care and how leaders can create a culture that's nourishing to everyone involved. Finally, we'll hear from Dr. Patrick Marier about the federal and provincial policies that shape long-term care and what might work better. And if we can go back to my soil and gardening metaphor one more time, I think of these three perspectives as what the Iroquois call the three sisters. This is an indigenous method of gardening in which corn, beans, and squash are grown together in a perfect combination. Corn provides a natural pole for bean vines to climb. Bean vines help stabilize the corn, making it less vulnerable to the wind. And along the ground, the squash vines create a natural mulch. It's a perfect system in which each level is needed and each supports the others. So Patrick's talk on policy is like the corn at the highest, tallest level. Barb's talk about the on-the-ground, personal and interpersonal experience of care is like the squash. And Pat's talk about the structure of care is like the bean vines that connect and support the two. So I hope that helps you as you listen to what they have to share. And I hope our speakers don't mind that I've compared them to vegetables. Now, as you listen to each speaker, please remember to put your questions and comments in the chat along the way so I can bring them into the discussion at the end of each presentation and in the panel. So Dr. Pat Armstrong is Distinguished Research Professor in Sociology at York University and a Fellow of the Royal Society of Canada. She's the principal investigator of a 10-year project called Reimagining Long-Term Residential Care, an international study of promising practices. And that's going to be the topic of her presentation today. She's also co-investigator in a range of other international studies related to aging and long-term care. And Pat was having some difficulty with her connection quality. And so there's a possibility that she will be voice only at some point, but we'll always be able to see her slides and hear her, just to let you know. So Pat, over to you.
I am unmuted, I hope, and you can hear me. Yeah. Thank you all for being here, and thank you to the organizers. I want to begin by saying that I know I keep breaking up, but my activism and research on long-term care really began in Montreal when my daughter broke her leg and ended up in traction in the hospital. And I had been doing research on women's work, and I thought, oh, the hospital is the perfect place to study women's work. That led me to study home care, and pay equity more than 20 years ago led me to start studying long-term residential care. And I thought in these places, we saw an incredible link between women's paid and unpaid work. And of course, in long-term residential care, we're talking primarily about care for women, by women, many of them from racialized and immigrant groups. And I think one of the reasons that we place so little value on long-term care is related to that female dominance in the workplace and of the population. So I want us to think about gender as we're going through this project. As Michelle said, I've been working for the last 10 years on an international interdisciplinary project. And on the second slide, you will see which countries that were involved in this study. I'm sure you recognize flags from Norway. And I'm going to turn off my video with the hope that that means that I can continue to talk through this presentation. So in my second slide, I talk about some overall conclusions from this international study. In my third slide, I guess, if we're counting this slide. One of the things we did on this project was take teams of up to 14 people into long-term care facilities in the 6 different countries, and we stayed for over a week, and all the teams were international and interdisciplinary. And it's partly on that basis that I want to talk about today. And our conclusion is that there's no single model that provides the perfect answer for long-term residential care. We'd say there's no magic solution. And that is in part because context and populations matter. It does matter what kind of home you're talking about in northern Quebec, for instance, compared to Montreal, or even comparing Montreal and Quebec City, or if you're comparing any of those to Toronto. So we have to think about the context, but there are certainly principles, standards we can develop so that we have standards rather than standardization based on the kinds of principles we've already heard about from Michelle. But in developing these strategies, we would argue there are tensions integral to this process that we're not going to get rid of, but we have to think about. And one of the most important is the tension between safety and joy. We have to think about safety, of course, but that can't be our only concern, because a life without risk can be very boring. So I think we have to think about both when we're talking about reforming long-term residential care. So in the next slide, I talk about what I think should be the basis of the structures that we're going to hear more about from Patrick and from Barb. And we start with the notion that care is a relationship, which is partly why we don't talk about person-centered care, because we talk about both the person who's providing care and the person who needs care have to be in a relationship of dignity and respect. To support care as a relationship, we need continuity in terms of who provides the care under what conditions. We also need non-hierarchical decision-making so that people can be involved in making that decision. And one of the things I noted on the previous slide was that we have to include all services. We feel very strongly that we need to think about food, we need to think about laundry, we need to think about cleaning as essential components in care, and we have to think about all of those people as care providers. And if you look at the military reports that came out of Ontario and Quebec, it's very clear how essential these aspects are to care. And all of those people have to be included in a non-hierarchical team. And so we have to think about the clinical, about the social, about the physical, about the active. All of these are aspects, but sometimes they are in tension with each other. And of course, listening and communicating have to be critical as well. If we look at the next slide, I want to talk about one of the central contentions in our projects, and that is that the conditions of work are the conditions of care. And I should have said previously that when we talk about all of the people involved in long-term care, we're talking about everyone who lives in, everyone who works in, and everyone who visits in long-term residential care when we're doing this planning. And those conditions, of course, start with adequate staffing levels. I know that it's common right now to say that that should be at least 4. I would say hours per day, resident per day. I would say that it needs to be significantly higher than that, but we need to at least get to 4. And that it's not just the number of people who are there and actually there rather than on the books who are providing care, but the composition of who's there and the training. It is different providing care in long-term residential care than in a hospital or in home care for that matter. So we have to think of the specific kinds of skills that are required. And it means working, as we've learned during this pandemic, for a single employer and for making their work full-time as much as possible, which of course is also important for continuity in care and care as a relationship. We have to, as we've learned throughout this pandemic, pay attention to the pay and the benefits and the shift length and when people work and what kinds of options they have about what shift they're on. We also have to think about equipment and supplies, and that's not just PPE. It's also soaker pads and adult briefs and snacks at midnight. There's a whole host of supplies that are essential if those people who provide care are going to respond to individual needs. The staff also need some autonomy so that they can use their training to respond to those individual needs. And that also means that we should not be contracting out services within long-term care. I could go on and on about food. I could go on essential they are to care, individual attentions we've talked about before. Clothes are critical to dignity and respect. And so that means laundry, it means time, it means a lot of things, as we explain in our book, Wash, Wear, and Care. We also have to attend to physical spaces. This has come up a lot in my province because of the 4 bedrooms, but that's not the only aspect. We need surge capacity. We need much smaller units. We need to attend to what makes people feel safe, not just safe, but at home. And of course, we need daycare, and we have to think about families and volunteers. My next slide was about gender, but I've already talked about that, I think, and I want to make sure that I don't go over my 15 minutes. So I want to move on to the slide about governance. Governance issues are critical. Who gets to decide? I've partly talked about that in terms of governance within, in the sense of requiring some autonomies for those who provide care so they can decide about individuals on the basis of their training. And our larger governance structures need to include families, they need to include staff, and they need to include volunteers as well as residents. And they need to include some public participation in deciding what care looks like and what kind of care is provided. But as the BC Seniors Advocate has made clear, we actually don't have verified data on aspects like staffing, like aspects like where does the money go, what do the managers earn, where does the profit come from? And that's increasingly important in your province and mine, given that we have the highest proportion of for-profit activity within the sector. And I'll come back to that at the end if I have time. So we want accountability, but if we're going to have accountability, we have to have verified data, and we have to make better use of the data. We collect an enormous amount of data right now. And in fact, what we have seen in our research is that scandals that get prominent in the media end up with the primary action in our country, at least, and in the United States too, with more regulations. But there tends to be regulations about the staff rather than regulations about management. No province has a kind of staffing requirement that all of the research indicates is necessary, for example. And we have to have better means to access quality without increasing that documentation. We see people sitting down to help someone eat and having to fill out forms about how much they drink rather than spending their time encouraging them to have their tea or their orange juice or whatever. So we don't need more documentation. We need better documentation and better things done with that documentation. And then finally, I want to go on to the question of profit, which is the next slide, which doesn't really say very much, except that I think it's important to understand that we have seen in both of our provinces not only an increase in the ownership of the for-profit ownership of the homes themselves, in the extent to which we rely on contracted services to for-profit companies, especially in food, but also in cleaning and in laundry and security, and even in terms of hiring agency workers. All of that disrupts the kind of continuity and care that is essential to care as a relationship. It results in I think, the worst meals, and we have sacrificed ourselves and eaten in every one of the 27 homes in the 6 different countries we've been in. Sometimes the food was very good, but sometimes we didn't even know what we were eating. And those were places where the food was contracted out. We have to make sure that the money goes to care, and we have to look at the arguments that are made for profit. The argument is that they save money. No, they don't. In both of our provinces, the not-for-profits, the public-owned and the for-profits all get the same funding from the government. So that doesn't save us money. It doesn't give more choice, because in both of our provinces, there are long waiting lists to get into care. It doesn't make the care more efficient. In fact, the efficiency tends to be defined in lower staffing levels in the for-profits. And I find it very difficult to understand how we can justify our public money going to make profit rather than provide care. And finally, in terms of for-profit, that it is very hard to have democratic control over this public money when there has to be, according to the rights of commerce, for those companies to have some right to secrecy. So I think for all of these reasons, we need to move towards more public provision of care, and we have to work towards profit as a motive within providing care. I was going to talk about federal initiatives as well, but I think Patrick's going to talk about that. So I'll move on to our last slide. That is about knowledge sharing, and the next slide, please, after the federal initiative, this one. These 4 small bouquets, as we called them, provide ideas worth sharing, as we like to say, rather than some kind of magic formula, the issue I started with in the first place. But it provides examples from the 6 different countries we were in about ideas worth sharing in terms of physical environments, in terms of promising practices, in terms of the labor force, in terms of what we call exercising choice. How do we could create the conditions that it's possible for all of those involved in long-term care to have real choices? And finally, we talk about negotiating the tensions I mentioned in the first place. That we have to think about and balance. You can get these 4 booklets to download without cost on our website or from the Canadian Centre for Policy Alternatives. And our website is in the last slide, but I'm sure it will also be made available by the organizers. So thank you very much. I think I kept within my 15 minutes, and I am very much looking forward to your questions and for further discussions of the topics you identified as central. Thank you.
That was fantastic, Pat. Thank you so much. And there are some great questions from those who are participating. I'll start with one that was asking for clarification. You had a chart, a slide that named some numbers, 4.5 and 5.5. Was that employees per resident? What were those numbers referring to?
It's hours of direct care per resident per day.
Okay.
The 4.1 hours is based on research done more than a decade ago in the United States, before the level of complexity was the same in terms of residents. As I'm sure everybody who's listening knows, that you don't get into long-term care these days unless you have very complex needs. And that was quite different when this initial research is done. So the 4.1 hours of direct care is the lowest possible limit, and no province sets that or jurisdiction in Canada sets that as their minimum. And when you talk about those minimums, you don't mean people who are on the books. You mean hours actually worked. So it can't include people on sick leave or maternity leave or vacation or whatever, who's actually there to provide the care. And one of the members of our team, Charlene Harrington, who is an enormous expert on these issues in the United States, would say that the hours should be as high as 6.5.
Mm-hmm. And you said no one mandates 4.1. Is there a provincial minimum in place right now? Or national?
Not in Ontario and Quebec.
It's not named at all.
Patrick could clarify that for me, I think, or for us.
Okay.
I don't. In Ontario, the only requirement is that you have a registered nurse on shift. That's it.
Okay. So these are sort of industry guidelines, but at the discretion of the facility at this point.
This is what the research tells us we should have.
Okay.
But it's not what we have anywhere in Canada right now. Although it has to be said, in part as a result of a report we did for the City of Toronto, in their 10 homes, they have promised that they will go to at least 4.1.
So we're trying to get up to these numbers.
Yes.
Is that right? Okay. All right. That's it's nice to hear the connection between your research and the results within the industry. So one of the questions was a wish for a story or two. What were some of the best examples that you saw in your research and your travels, and in particular of this balance between safety and joy, or the dignity, the duty of care, and the risk? That was a fascinating. You said something about a life without risk would be boring. That's such a powerful concept. So, what are some examples?
Well, one example I love to use was from Norway. We were in a home that was physically integrated into a huge complex that included the town cinema, the town swimming pool, a daycare center, a spa, a climbing wall. And one of the phrases they used was that residents could go to all of these things without putting their boots on. That you could actually move around. And so if your children brought their children to go swimming in the pool, grandma could walk down the hall and go and see them, or be wheeled down the hall and go and see them.
Wow.
So that's one example of a story of an excellent way of going in terms of the future. And I would like to, I am going to answer go to the question about risk and joy, but I also want to say in terms, before we rush to say we shouldn't have long-term residential care, I have to say that I spoke with a residents council here in Toronto that's physically in a building that's not very attractive. It's a very, that era where architects thought everything should be made out of cement blocks, and it's just not a terribly physically pleasant place to be. But we asked the residents council if there was anything better about being here than at home, and they said yes. First of all, I feel safe, and by safe they didn't mean what we often think of as safe. One example they gave was someone makes sure I have my insulin.
Mm-hmm.
A second reason was we always have company. If I was at home, I'd be all alone. The third one was that we have activities. And they said, I know that we get accused of just having a television on and sitting in front of it all the time. But if I was home, that's all I do. And here I get to do other things. So I think we have to think about the ways we can make congregate living as good as it can be. And that means making it fun and and providing some kind of joy. And to go back to the risk question, one example I will use is when we were in another home in Norway, as a person who was called an occupational therapist was walking with a man down the hallway, and he was quite unstable on his feet, and yet she was encouraging him to walk. And I asked, what would she do if he fell? And she said, my job is to make sure that he is acting to the extent of his capacities. And yes, sometimes people fall, but I could catch him, and whenever someone does fall, we get together and try and figure out what it was about falling that we could think about doing in an alternative fashion. Mm-hmm. And that contrasted so much to places we were in Canada, where families said, my mother walked in here and they put her in a wheelchair right away because they were afraid of falls, and now she can't walk.
Mm-hmm. Mm-hmm.
So that's one of my one example. I could give you a lot of examples. We close the balconies in this province because we're terrified people will fall off the balcony. Nobody has.
Mm-hmm. Mm-hmm. And then all of that shows up as those concerns that people brought up in the registration, that the residents lack autonomy and they lack meaning and purpose and engagement. So there's
I'll give you one other example. We were in a home in BC where the majority of the population was Asian extraction, and they wouldn't allow soy sauce because they said the salt content was too high. These people are in their 90s. They've been eating soy sauce since they were small, and it's what makes food taste good. Mm-hmm. So I think you could risk a high salt intake and enjoy your food.
Wonderful. Wonderful. Well, I'm happy that we get to talk with you again during the panel discussion. There are more questions, great questions, so we'll save those for the panel. And thank you so much, Pat. This was really fantastic and insightful.
Thank you.
And yes, it's time to move to our next speaker, Barb Sutcliffe. And I can tell you that Barb has been working in the elder care sector for over 30 years and is the Senior Director of Sales and Marketing, as well as a culture change coach with the Schlegel University of Waterloo Research Institute for Aging. She has worked with many homes on their culture change journeys, and Barb is a registered nurse with degrees in sociology and gerontology. So Barb, over to you.
Yes, good morning. I'm so excited to be here with so many like-minded people that are wanting to see changes happening in our retirement and long-term care sectors across the country. As you mentioned, I'm at the Schlegel UW Research Institute for Aging, and it's a charitable, not-profit association a foundation that enhances the care and quality of life for older adults. And we do that through research, education, and practice. And we try to drive innovation to tackle some of the biggest issues that are facing our population. And then we share what seems to be working. Next. Yeah. All right. And we'll go on to the next one here. So we'll start off by talking about what culture change is. And Bill Thomas is one of the founders of the culture change movement in the United States. And he did the keynote address at the first Canadian Culture Change Conference in 2014. And this is what he had to say. There is no one old age. Old age is what we make it. And unfortunately, in North America, we live in a shared culture that has come to regard old age as a time of decline. We've come to think benevolently of older people as broken versions of their formerly impressive selves. This really needs to change. The culture change movement can help us do that. Most long-term care and retirement communities or organizations operate in an institutional or in that medical model of care. And this approach often diminishes the quality of life of the people that work there and the people that live in those settings. Changing organizational culture is really difficult, but it is possible. In the most general terms, culture change is a social movement that supports that shift from the institutional model of care towards that social model of living, a focus from providing care to supporting living. It goes without saying that we do need to be providing excellent resident care, but it shouldn't be the central focus of each interaction that we have with our residents. So culture change is really calling us to put culture first. So over the last several years, the term culture change has become more widespread in our sector. And as a result, it's important to be very clear about what culture change is, and even more important about what culture change is not. Culture change really needs to be championed by collaborative leaders. It needs to be mobilized through partnerships and engaging the stakeholders that we're working with every day. It's being open to new possibilities. It's thinking outside the box, not doing the same thing all the time. It's an evolving process. It's not an end target that we're reaching to, but it's ever evolving. And it's looking at an organization and what they do well. It's building on their strengths and being able to look to the future and where we want to go. Culture change is not a top-down mandate that should be implemented or imposed by other people. It's not an end product or an outcome that we're working on. It shouldn't solely be a quality improvement initiative. It's a journey that we're taking, and it's an ongoing journey. And it's not a specific model of care that we're using. And as we keep hearing, it's not a one-size-fits-all approach. Each journey is very unique to the organization. So culture change requires changes in fundamental organizational and individual beliefs and philosophies and practices, in physical environments, in relationships at all levels, and in workforce models. These kind of changes lead to better outcomes for our elders, for their families, and for our care workers. If you want to act differently, you need to be thinking differently. You have to change the systems to support our philosophy. Rosemary Fagan, one of the pioneers of the culture change movement, identified several domains that demonstrate the difference between the medical model or the institutional model of care and the social model of living. So I'm just going to go over some examples of some of these. With the primary focus, it's looking at what the organization and the team members perceive to be that primary focus. We still need to provide that excellent health care, but within a transformed culture, the individual care needs aren't the center of every experience. For resident and team member routines, it's the way that we schedule the teams and carry out their day. We have to start thinking about life as the central focus of care. It's important that routines become more flexible. Just as you and I wouldn't want to have to get up at the same time every day, or most of us, or eat the same food every day or at the same time, so too do our residents crave to have the freedom to be able to enjoy the day as it rolls out, and not having to adhere to strict schedules. With team member assignments, it's how we're scheduling our team members to work. We need to stop rotating them between neighborhoods and between residents, and to help schedule them so that they're assisting the same residents on a daily basis. Team members support residents with very intimate care, and it's important that this care is provided in the context of a meaningful and trusting relationship. Creating team member schedules centered on a dedicated support allows our residents and our team members to develop those strong, deeper, more meaningful relationships. Just think of receiving a bath. If you don't have a dedicated resident schedule, you could have up to 25 people that would see you naked every time that you had a bath. But if you can get into having dedicated assignments, you could get that number down to 6 or 7. How would that make you feel? Just think of it, of having to expose yourself when you've never had to do that all your life. Decision-making domain, we're looking at countless decisions that we make every day. And as much as possible, we want to be able to turn those decisions over to our residents. And it could be as simple as, do you want to wear the red socks or the blue socks today? Would you like to have the dress on, or do you feel like it's a pant day today? Engage our residents in the decisions that they are able to make at every opportunity. That demonstrates respecting who they are. With our physical environment, the way that we view the physical environment makes a really big difference in the way that we approach our residents. The way that our team members see that physical environment, we want to give power back to our resident. It reminds us that we're there to be able to support our residents. Residents don't live in our workplace. We work in our residents' homes. Just as we wouldn't go into our neighbor's home without first knocking, we need to give that same respect back to our residents. Knock on the door and say, "Hi, it's Barb, can I come in and see you now?" If we're looking at our activities in the recreation and leisure domain, if nobody wants to participate in a program that's scheduled that day, why not change it up? Find out what they're wanting to do in the moment and look for something else to do. There are obviously some things that have to be scheduled when you have entertainment coming in, but take opportunities to live in the moment and see what the day feels like. On a beautiful day, maybe instead of sitting and doing a bingo, you're going to go outside and sit outside and listen to the birds. We want to collaborate, to use a collaborative approach when we're looking at departmental structure, in which cross-functional teams work together to support the well-being of our residents. In the institutional approach, certain roles are seen as more important than others, and we're trying to flatten this. Instead of working in competition with each other, we need to be working in collaboration with our teams and recognizing everybody's expertise just as it is. It's a difference. None of us are better than any others. We can all empower our residents to live well. With relationships, we want to make sure that our relationships that we're developing are less one-sided. And the social model of living empowers members to find that balance between professionalism and that intimacy. And the balance is going to be different depending on the role that you play. Looking at our sense of community domain, it's the degree to which the residents, our team members, our family members, all of those stakeholders feel like they're in this together. In healthcare, there's many cases where there's an us and them mentality, and that attitude exists in a lot of places. The culture change movement calls us to build that spirit of inclusion, to create communities where every person in it thrives. During his keynote address in 2014, Barry Barkin was there, and he's a giant in the culture change movement in America, and he explained what culture change is all about. He says, our task is simple. It's to build communities in which each and every person matters, in which we are all connected to one another. And it's even better than that, in which we're all, our mission is to create the culture of aging in which we all want to age, despite what other vicissitudes come along in the journey of our own aging. So we're often asked, you know, what's the best approach to culture change? Just going to flip that back again. There we go. Thank you. In truth, there really is no perfect solution. There is no one size fits all. We all have very unique strengths and opportunities for learning. And the best journey is the one that works for your organization, building on the things that you're already doing really well and doing more of it, that it can flex as time goes on. You'll have a plan in place, but it's always going to be changing. It's also going to be based, you talked about planting the seed, Michelle, and it's based on those mission, visions, and values that you've worked so hard to establish for your own organization, and making sure that it's grounded in those principles. We want to come and create a resilient, deep system changes. We're not looking for Band-Aid solutions. We need to build a solution that's going to stand the test of time. And these deep system changes occur at 4 different levels. And the first one is the personal transformation. Rosemary Fagan says that culture change begins within ourselves. Personal transformation is hard because it involves a critical self-reflection. It's all about the way you talk. It's all about the way you act, and it's about the way that we interact with one another. Next, we're looking at operational transformation. This requires very strong philosophical and practical commitments from the communities that we're working with. Communities need to respect the members and as the experts in the things that they do within their own lived experiences, and who are able to determine the roles and goals and as part of that culture change process. Members of the leadership team need to be humble enough to realize that there might be different ways of doing things, and that the wisdom to make the changes already exists within your organization. You just have to tap into their strengths. The transformation is all about the process and not the outcomes. Then we get into environmental transformations. There are some physical designs that really perpetuate that institutional and medical model. And one of those things is a nurse's station. Pat talked about a number of the older organizations and their structures where there are still 4 people in the room. But you know what? Transformed cultures can still exist in ugly buildings. You can repurpose the rooms. You just have to make sure that they're grounded in the operational transformations that you've identified are going to be key and important for your vision of the future. And lastly, we're looking at societal transformations. Society needs to provide more knowledge about the aging process. We need to provide opportunities for youth and our elders to come together so that we can help them change the view of the aging population. So the RIA uses the appreciative inquiry approach, or AI for short, during all of our culture change journeys. And we believe that you need to embark on a collaborative journey that's going to be guided by shared values and supported by your community's own strengths that seek to honor, to celebrate, and to build on the quality of uniqueness that already exists within the organization. And the AI process is made up of 4 cycles, or the 4 Ds. The first one is the discovery phase, where you're appreciating what's happening. What gives your organization life? And what are you already doing well and building upon those things? The second one is the dream phase, and it's envisioning what that future looks like. What is your dream for that ideal future? Let's talk with all our stakeholders to find out what that is. The design phase is looking at co-constructing. What do we need to do to get to that ideal future? What kind of things do we need to put in place to make that happen? And again, all of these things are collaborative processes that we use. And the last one is the destiny. How are we going to sustain this momentum? What do we need to do to keep this going? So we're looking at the role of the leader, which is very critical in a culture change movement. You need to have effective change leaders that embrace and model the values, that are able to be visible and curious, that are able to stimulate people that you're working with to share their ideas and to be brave enough to put themselves forward, to be collaborative and to communicate with all of your stakeholders, to build trusting relationships and improve the self-esteem of everybody that lives and works within the organization, to be able to promote growth and build future leaders and collaborate with them. And most of all, to be able to share thanks and praise within the organization. We need to be able to be visible and make sure that we're able to access all of our team members, that we're able to close that open door, that we don't want residents and family members and team members to have to come to us. We need to be out on the floor and be visible and be part of what's going on. We need to visit the team members regularly and ask them the questions. Why are we doing this? Or what should we change? And what's stopping you from being able to make the changes? How can we improve this? We need to form a collaborative system in our homes that enable high involvement in discussions and in projects at every level, no matter how big or how small. Ask people what they think. Use huddles, use learning circles, use whatever you can to bring people together and have the conversation. Learn and apply the conditions of empowerment about information, the parameters, about providing training and skills and additional resources as needed. We need to share our thanks and praise, but it needs to be genuine. Find the good in every effort that we have, regardless of the results, because not everything is going to be successful. Reflect on your shared values and acknowledge when they're displayed. Be completely honest. Only give honest praise, and do it often. Explain specifically how a team member has been able to help the organization with all of its actions, and smile and enjoy the journey. There will be trials and tribulations along the way, but it can still be very enjoyable. We need to be able to keep the momentum going. You're going to have a plan in place, but in reality, there's going to be lots of bumps and valleys along the way, and enjoy them as wonderful learning experiences. You need to be accountable. How will you define what success means? What are going to be the key performance indicators that you're going to be looking at or measuring? How frequently do you need to be checking in? And who's going to be responsible for making those measurements happen? And you need to celebrate your achievement. And this was a celebration of one of the organizations that we were working with, and recognizing all of the successes along the way. There's usually not one monumental change that's happening. It's all of the little things that are so important. It's empowering your team members. It's empowering your residents. It's providing choice for your residents. It's all of these things that you have to celebrate. And some words of wisdom from an organization we work with. They said these are some of the things that people really wanted to know. And it's take small steps and really move slowly. This isn't a race to get to the finish line. Admit when you don't know something. Be honest. Get the word out to everybody and make sure you're a good communicator of what's happening and what's working and what's not working. Work on team building and role clarity. Develop trusting relationships with everybody and give yourself time. But what if we fail? Well, failure is only the opportunity to begin again, only this time more wisely. Thank you.
Thank you so much, Barb. There was so much inspiration in everything you shared. And we have lots of questions and probably time for just one or two. Again, as with Pat, I wonder if you could share a specific story. And one of the toughest nuts to crack in culture change, particularly in this context, is the hierarchy. And I wonder if you have a story of how any group was able to transform rigid hierarchy into something that was more flexible and responsive.
I think the biggest thing is when you're going to your team members, if you use huddles or learning circles within your community, and making sure that all the stakeholders are represented there. And just starting with your dietary aides, with your housekeepers, with your maintenance personnel, with your personal support workers and nurses, being included instead of having huddles where it's just the nurses or the personal support workers together. It's bringing all of them together and asking them all the same question, and valuing each of those individuals as being important players in the role. And it empowers them to be able to realize that their voice is really valuable. When you think of your day-to-day care and support of residents, who spends more time with the resident on a daily basis? It's usually the housekeeper that's in and out of the room, emptying the garbage, chit-chatting, and being very relaxed with the residents. How valuable is that person's voice in what's happening with that individual, to be able to share their hopes and dreams? Is the first and one of the most important things that can happen within a home.
Wonderful. Can you say a little bit about the collaboration with family members and how, in particular, this concept that that Pat raised, the trade-off between risk and safety, joy and safety? I think she's talking about life, the trade-off between life and safety that you're bringing up. So I wonder how those conversations go with family members who are, and residents even, who are having to make that choice.
Yeah. So, if a home is embarking on a culture change journey, one of the early things to do is to bring all those stakeholders together and to talk about these kind of things. And to bring a family member along with a personal support worker and having the same conversation, but your mom really wanted to go down and take off her shoes and put her feet in the pond today. And, just to be able to have the conversation, but what if she trips? She doesn't have her shoes on, and to be able to have that, the positive and negative is expressed in the presence of the family member, in the presence of the family of the team member, and all the key players, so that they're hearing both the positive and negatives, and putting yourself in the perspective of what would you like to do in 20 years' time if you were going to be living in this home, and really asking the question of that family member. Would they really want to not be able to do the things that they love to do every day just because there was a risk of something happening?
Wonderful. All right, that's what we have time for now, and we'll see you again in the panel. Thank you so much, Barb. That was wonderful and very inspiring. So now we have the pleasure of hearing from Dr. Patrick Marier, who is the Scientific Director of the Center for Research and Expertise in Social Gerontology. His research focuses on aging and public policy, and he's going to speak about the impact of COVID-19 and long-term care policy for older people in Quebec. Patrick, it's over to you.
Thank you, Michelle. So we'll first start maybe with this second slide. Pretty much my journey to this topic is very different from Pat. I was in the deeply embedded in the world of pension policy, and then I was looking for new challenges, and then I was approached to lead CREGES, and I've been in CREGES ever since. So I pretty much went from Bay Street to the CLSC René Cassin. So that is a culture change, right, in itself. So what I'm going to talk to you about today has a lot to do with how COVID has risen, has raised a lot of specific questions in regards to long-term care. Now we can move them forward. But beforehand, I want to say just a quick word about what is CLEGES. CLEGES is an infrastructure that aims to improve practice by research, but also improve research via practice. So I've left all of the information here, and we're easily accessible on our website. And on the following slide, I just want to talk a bit briefly about the Team B, which I'm also highly involved with, which has to do with aging, social solidarity, and social exclusion. And as part of this, in the next slide, so we have 2 books that aims to target a very broad audience, and it was so popular in French. It was even the leading selling book in Presse Université Laval for a good chunk of 2018, that we succeeded in convincing a Canadian English press to actually do it. So I've used all of the arguments from Seniors Action Quebec in this case to make the case that it's okay to have an English book that talks a lot about Quebec. It was a tough sell, but it worked, and we're glad to tell people that they would be available. The launch is scheduled for October 1st, which is the same day as the International Seniors Day. So now if we talk about COVID, so in the next 2 slides, I just showed a bit the latest figures. As you can see, COVID has been particularly problematic in long-term care residents, but also in seniors' home. And as we see in the next slide, that's particularly been the case in Quebec. And as of the latest figures, 72.5% of COVID deaths in Canada that occur in long-term care residents, CHSLD nursing home, and seniors residents actually are from Quebec, right? And sadly, as is often the case in public policy, it took quite a tragedy to actually raise, right, and put finally on the political agenda the issues surrounding long-term care. And then in the next slide, so we go a bit, explain as to why long-term care is such at the margins in Canada. So we'll show in the next following 2 slides, but we will stick to that one for now. And we'll see as to why is long-term care so not taken seriously in Canada with regards to other countries. The first important element to notice, and that a lot of people seem to be amazed by, is that in the Canada Health Act, long-term care is actually an extended services. So concretely what that means, so there are no provincial obligations to actually even provide, long-term care. So there's no standards mandated, there's no regulations standard. So as a result, we have 14 different regimes of long-term care throughout the countries. And in some cases, they've evolved in very divergent manners, right? So that, for instance, would be in British Columbia, where 87% of the beds are in the private sector, while in Quebec, it's 87% are still in the public sector. And also quite indicative of this marginal status. So if you look back at all the major healthcare commissions we had in Canada, long-term care is usually not even mentioned. So it's not even addressed. And even in the statistics that I will provide in the next 2 slides, if you look at the health at a glance from the OECD, so long-term care are the last 4 or 5 pages out of the 160 pages document. So there's a pattern, right? Consistently, if you look in health, and when you talk about long-term care, it tends to be very much operating in the margin. There's also the issue of policy feedback, which had to do with the way we developed healthcare in Canada. So it was originally created as a hospital-centered model, and that still matters greatly when it comes to long-term care. First of all, we operate with a very strong curative model, right? And when we deal with people in long-term care, it tends to be chronic condition. We don't aim to necessarily to cure sickness or cure chronic conditions, but we instead try to make their life better, right? Or alleviate a lot of the hardships surrounding these conditions. There's also, if you look what has happened since the financial crisis of 2008, when we made a lot of cuts in healthcare, now we are restoring some of these cutbacks. If we look at how much we've cut and how much we've actually restored the funding, long-term care funding has lagged behind these other areas on healthcare, even though there's much growing need with regards to an increasing older population. There's also another major issue, and that's derived from this hospital-centered model, is the fact that long-term care problems tend to be framed as alternate level of care. If I put it bluntly, when we had this merger reform in Quebec, the first questions I had from colleagues in the medical field was to say, well, Patrick, what are you going to do to make sure that seniors don't crowd out hospitals? So that's the way the leadership thinks usually sometimes about long-term care as a first foremost as the primary issue. And the other specificity from Canada, which tends to be ignored a great deal, is that in all the countries where long-term care tends to be to be more generous, both in terms of coverage and depth of services, municipalities tends to be highly involved, which is actually not the case at all for most provinces. So they are much more involved, for example, in Ontario, where even the city of Toronto, for instance, have few nursing homes. And I think there's still 30% of nursing homes that are run by municipalities, but from what I understand, it's a dwindling model. While in Quebec, it's clearly in the hands of the Ministry of Health and Social Services. So if you think about these issues I just mentioned, and you look at a comparative picture, like in the next slide, you can clearly see in terms of the global assessment, I hope you have a bigger screen at home, that Canada only spends 1.3% of its GDP, right, on long-term care. That's about much less than Norway that Pat mentioned. So since she went on Norway, I'm going to go on Norway in my comparison, which is about 3.2%. So that's a substantive lower amount in terms of spending that we do on long-term care. As a result, and that's a bit in the next slide, another important characteristic which reflects a lot from the hospital-centered model is that 82% of our long-term care budget is actually in institution. And that's despite the fact that we've had for 20 years, almost all provinces have literally made a move towards healthcare. If you look at the budget, it hasn't budged. So we're pretty much spending how much on nursing homes today as we did 20 years ago. So that's really run counter to the policies that we have now adopted. And another important consequences of this, so lack of funding, you spend a lot on nursing home. So as a result, if you look at the graph below, we only cover 4% of the population that is 65 and plus. So that means we target individuals with very high complex need, and we are leaving behind a lot of older adults that could actually benefit from these kinds of policies, which if you look at Norway, I cannot see it that big on my screen, but I think it's about 15.5, 16% of the population that receive services, right? And there are a lot of benefits for actually even targeting individuals that have lower care needs and usually act as a good preventive measures and a lot of health indicators were showing lower hospitalization rates, less likely to have major health incidents and so on. And it's also is highly beneficial, which we don't talk a lot, for the ones who are providing care, who can combine a career and providing care, which is a very major issue when you're talking about an aging population and you want to maximize the number of individuals on the labor market. So then we go to the next slide. And that brings me to talk about the biomedicalization of aging. So when I bring this up to political science, they look at me like this is some sort of abstract sociological concept. But in reality, it matters greatly when you talk about aging as to why we're not able to bring the type of elements that mentioned by both Barb and Pat with regards to having a more social flavor to the way we actually provide services for older adults. So the first element is that mentioned a bit earlier is that aging rests solidly in the healthcare and medical field. So demonstrate that in the past few slides. And if you look, as a result, there's a strong institutionalization of aging and health, right? So there are multiple consequences to it. So I have a forthcoming book myself that goes to these at length. But if you think about research, right, the Institute of Aging is within the Canadian Institute of Health Research. So already it's not, on an independent institute that collects all three of them, but it is clearly within health. And as a result, a lot of the researchers encourage is research that focus on health outcomes and not necessarily social outcomes or other type of outcomes that we can also wish to have. Another element that we've seen, and that's across through all 10 provinces. So when we've had a lot of efforts to create aging offices that are independent from health ministry, and in a lot of these cases, if you think about it, it's really a game of chute and ladders. So the ladders tends to be from more health-based initiatives, and the chutes are for the social initiatives. In many cases, a lot of these social offices for older adults have fallen back over time into health ministry and social services. And if you look at what's happened with Quebec and our senior secretariat, right, our minister now is back firmly into the health ministry. Another element that tends to be underappreciated, and that has to do with the fact that because we target complex need and we are gone more and more towards standardized assessment instruments, these instruments tend to eventually shape what people think their autonomy should be like, right? So when we did a study of older adults with focus groups in Quebec, we asked them questions about their social well-being, and we purposely avoided anything to do with health. And then when we asked to them, well, what does it mean, the word autonomy for you? They are literally were answering us by giving us elements that are straight from the ESOS math assessment, right? They're talking about number of baths per week. They're talking about how, the number of times someone will come and help them clean their apartment. So there's an important feedback that if your instruments tells you that what matters are purely functional and cognitive elements, then individual will start thinking, well, this is really what my autonomy should be like, right? So it's hard to have culture change unless we succeed at the demonstrating and ensuring that policymakers recognize that autonomy goes well beyond these elements. Another key element too, and that we see in terms of major tendencies, is that more and more the home care programs tend to be focused also on rehabilitation instead of other type of long-term care needs. And a good example of that is a study in New Zealand, and I think it was Pat who talked about the data and numbers that we've had ever. So the Auditor General of New Zealand mandated a study of comparing the use of their traditional assessment tool, which tends to be regionally based in New Zealand, and also now to use the Interi, which is the most popular assessment tool. And then they found out that in the end, in terms of health outcomes, they were both exactly the same. However, the use of Interi meant a deployment of resources into rehabilitation, while the previous model tended to be much more supportive of the caregivers and the social need of older adults. So at the end of the day, you have the same results, but how you deploy these resources actually change drastically the way you're actually providing home care. And another element, which I always like to remind people, is that there's a lot of studies that shows that the more you spend on social services, it results actually in better outcome, better return for your money than on curative spending and health, both in terms of social and health outcomes. So I'll go to the next slide. So now, before, I've once been called a killjoy, so I want to go with success, right? So what are the things we could do, right, to change these elements? So if you look at the international literature, and I think that goes squarely with what Barb and Pat were saying, so the closer is the money, right, and the closer are the responsibility in terms of long-term care to the people involved in long-term care, the better it is, both in terms of how much you spend and how much services you receive. Another key element as part of this is to involve the cities substantially. And that's quite important because we talk a lot about communities and so on, but at the end of the day, the key political actors right closer to communities tend to be the cities. Another element is the key is that to have a genuine priority given to home care, which is not the case in Canada. Another key point is to have this not in the health ministry, as we currently do in 9 out of the 10 provinces. So New Brunswick is the sole exception that developed home care outside of the Ministry of Health, and it was a strong opposition from a lot of the medical profession when they actually launched home care. And if you look today at how much they spend per capita relative to the income of the province and the population. They're the leader in Canada on so many of these metrics. Another key point is to have a secure source of funding, right? So we see, especially if it's in a broader general health budget, literally, if I give you an easy visualization, right? So individuals waiting at the ER, it's a nice first photo op, but somebody waiting longer for their long-term care services hardly makes the first page of the Journal de Montréal, for instance. Sadly, that's kind of a political reality of these two pressures, right, that politicians face. Another element, and that goes directly with the previous presentations and also Pat, right, adaptability with regards to housing arrangements. And I think that's also a quite important features in order to have this kind of success. So I want to follow up with the next slide and link this back a bit to COVID and think about the responses. And it's very important that when we talk about COVID, well, this is right now clearly a moving target, right? So it's it would be very presumptuous to make a lot of conclusions on COVID. But what I wanted to show, though, in this slide, is to think about how long-term care was considered when COVID, became squarely on the agenda. If you look at what happened in Quebec, and there was a lengthy article in L'Actualité that talked about the first few days of COVID and how the government organized itself. What's very interesting is that the key actor were the Prime Minister, the Minister of Health, the Deputy Minister for the Minister of Health, and also the Deputy Minister of the Prime Minister, and communication expert, and our public health director. So the Minister of Seniors and Caregivers in that case was not actively involved in that part of the discussions early on. In New Brunswick, it was a very different take. So they created a coronavirus cabinet that included the Prime Minister, 3 ministers, and even the leaders of the opposition party. But what's really interesting is that from the get-go, the Minister of Social Development was involved. And why is the Minister of Social Development so key? Is the primary responsibility of that ministry is long-term care. So from the get-go on day one, long-term care was on the agenda. And it has to do with the fact that you have a minister that has the programmatic responsibility of long-term care, and that person operates and very at arm's length, very distinct from the health ministry of the province. So on that note, and I put a little link, we wrote a little, me and my colleague Daniel Bella at McGill wrote an article in French on long-term care and why these kind of different political constellation matter. So on that note, the last slide. So to conclude, if I have 2 big claims and message to convey with regards to culture change in general, and culture change in terms of policy and administrative change, I think it's very important that you have a political leader, right, or an office where you actually have somebody who thinks about long-term care 24 hours a day, 24/7, that it's their main priority, right? That also comes at the cost that you have to be careful also and be cognizant that you have to give them enough voice and power to be able to defend their turf, because in so many ways it would be a relatively smaller ministry than, let's say, than being incorporated in health and social services. So that's a reality to think and consider. Another element is that long-term care should be institutionalized within a departmental structure distinct from health ministry and regional health authorities to flourish. Thank you.
Fantastic. Thank you so much, Patrick. It's time for the panel discussion. So I'll send the first question on the panel to you, Patrick, but let's get set up so that we're all together in conversation. And Patrick, I want to just note how much you are mirroring what we heard from Pat and Barb and saying it in different ways, that the system right now is oriented to reduce risk and to fix physical problems, where what is really needed, more of at least, is focus on the social and the living and the joy, and that has benefits to the physical health as well, and that requires structural reorientation. I love the example from New Brunswick that it's under the responsibility of the Minister of Social Development, right? So how is this research of yours getting to the ears of those who set policy? Can you tell us about that and give us some hope, or tell us what we should who we should write to and how
it is very much a challenge, because a lot of these key positions are strongly embedded with health actors, right? And I think that is the challenge. A lot of it is to be persistent and continue to maintain a dialogue, and then it's a one step at a time, right? So that there's no in politics, like there's so many elements that would make a structural change. It can take decades, right, to accomplish this. So it's not something that could happen overnight. But it is key that to understand that right now we are what we would call in a policy window, because we talk so much about long-term care. And I think it's important to actually voice these concerns and make people realize that, wait a minute, if we're talking about long-term care, there are much broader issues, right? Like right now, for instance, in Quebec, we focus a lot on the pay rates of the orderlies. But I think, the issues we've been dealing with in long-term care are reach far beyond that. And I think that's important that individuals involved in long-term care voice this often, frequently, and not be shy to do it, even though in many cases they will feel like the voice of the healthcare sector is drowning them out. But I think the key is that if we just go away quietly, it's not going to change.
Exactly. I have carrying on from that, I'd like to ask Pat and then Barb, are you seeing a similar window, an opening to culture change at this moment in time because of the crisis of coronavirus or otherwise? Do you see it as a special moment for change? Or where do you see that showing up? I think we might have lost Pat for a moment. So Barb, I'll put that. Oh, sorry, you're here. Good. Pat, you go ahead.
I hope that it is an opportunity for change. I fear that it will be like scandals in the past. We will do a few things and there won't be much fundamental change. And I agree with both Barb and Patrick that we are talking about fundamental structural change as well as fundamental cultural change. I think that I mentioned in my first slide that we have to think about the tensions. And one of the obvious tensions that both of the others have talked about is the one between social and medical care. But there are also tensions in terms of what are seen to be the best options. Like we've interviewed lots of people who said, I don't want a private room. I want to have a room to share with somebody. Because I like the company, I can share their relatives, I have somebody to watch out for me. And of course you can get a creepy partner in the room, but if it isn't, it could be very rewarding. So I think we have to be very careful, as both Barb and I said, in consulting and talking, but prepared to there not being universal agreement. For instance, on the issue of nursing stations that Barb raised, we had lots of residents and families say, oh, I want the nursing station because I know where people are, I know how to find people. That we had the same kind of debates about uniforms. So I think we have to be aware that their tensions are there. I think, and to address questions that both Barb and Patrick raised, that accountability gets defined as counting. And we end up counting what can be counted. And what is most easily counted is the medical interventions. And it's really hard to count joy, or it's really hard to count the consequences of the kinds of cultural change that Barb was talking about, to show the result and to frame the reforms. So it is about, do I think we're going to get there? I think there's a possibility, but we really have to keep the pressure on. Or I think, as I said earlier, when we've had scandals, we'll get more regulations, and those regulations tend to be the ones that Barb was talking about as being, everybody has to be at the table at 8 o'clock for breakfast, rather than thinking about how do we create that kind of culture change and the possibilities for joy.
My understanding is that the etymology, the root of the word accounting is not counting, but raconter. It's to tell a story.
Yeah.
So if we could shift our understanding of accountability to understanding the story that's being lived, that might help. Barb, are you seeing a window opening up?
Absolutely. Pre-COVID, there was a real thirst from people wanting to make changes within their communities. And unfortunately, with COVID, so many people are just trying to keep their head above water right now. So the thought of adding one more thing to make change is really difficult, especially when you need to do that collaborative approach. You need to be able to pull all those stakeholders together, and that's not a possibility now. You can't have a forum where you can bring 50 people together that includes your family members, your community partners, your residents, your all of those people that need to collaborate together and hear the same message at the same time. And that's really where you're going to be able to make that change, that everybody's included, that you're really transparent and you're visioning together to make that change. You had asked about, families and what we see with culture change. And one of the big things that we noticed was in early days when we were doing an introduction to culture change, we asked people to hold up a red or a yellow or green paddle. Once you've done some of the exercise in envisioning what the future could look like, and asking everybody, do you see this as a possibility? Are you on board with this change? And there's always somebody that holds up that red paddle that says, you're pie in the sky, get rid of those rose glasses. But there's nothing more exciting than 6 months down the journey when you keep bringing these people back and you keep educating them and talking about what that vision could look like and how we're going to get there and how we can work around those regulations. And you do that again, and that person that held the red is now holding that green paddle. It just sends tingles through you to know, that light bulb moment's come, and they see that it really can happen.
That's wonderful.
But I think right now, people are just trying to keep their head above water, but it's coming. We're working with a partner now that's finally high enough that they're saying, can we get back at this? Like our team is ready to go.
Beautiful. I have a really big question for all of you that might help tell the story that would bring us past just keeping our head above water and just pointing blame. I wonder if all of these dreams of ours come true, if long-term care is able to be transformed, policy changes, the structure of care changes, the culture within the long-term care ecosystem changes, and then there's another pandemic. How will it be different? And I know it's a gigantic question, but I wonder if there's some examples of how it might lead to better outcomes if the changes that you've described could be introduced. And I'll leave it to anybody who has a thought to share.
Well, I think one of the things is remembering to put the resident in the center of all of this, and again, that transparency. Let them know what's happening. Don't keep them in the dark. Things are changing on a daily basis, and you just have to continue to communicate, because if you're not part of that change and you're fearful because you don't know what's happening, you just have to lay it out there and be transparent and answer questions as they come along. And again, that's with everybody. It's with your team members, it's residents, families.
That's a great example.
If I think that we have some things in place right now because of the consequences of COVID that Patrick so eloquently set out, like protective equipment and some training on those protective equipment, although I'm not convinced that it covers everyone who works in long-term care, going back to my initial point that it should involve everyone in terms of access to protective equipment as well as to training. I think that these are small things. That I think that if we insist that we don't give priority to hospitals, to go back to something else that Patrick said, which we did at the beginning, transferring people out of those homes, out of the hospital into the homes, that those are starting points at a bare minimum. But we have to, we could certainly make progress on the labor force. And I think that we could do it now. And I think it's going to take federal leadership to do this. That starts out with the notion of care as a relationship that means the kind of continuity Barb was talking about, which means that what we've seen in BC and somewhat relatedly in Ontario and Quebec, say, let's move to full-time employment where it's possible. But if people want to have part-time, that they work in one place, that they get paid decent wages. If we start with the labor force and their conditions of work, I think that we could really change the kind of output there would be in the pandemic, because we shouldn't forget a lot of healthcare workers died
Yes.
too.
Yes.
And that was also related to the conditions.
And there might not be as much cross-contamination if people are well employed in one facility. Yeah.
Well, to build on what Pat just said, I think it is quite amazing what BC succeeded in doing in such a short period of time. So it shows you that if a lot of the key actors at the table are willing to find a solution, it can be achieved. I think in the case of BC, if my memory is not failing, they found a way to tackle something over 50 collective agreements in less than a month's time. I mean, this is unprecedented in terms of labor relations. But they turned out to be very successful in actually making sure, and if we go back to the word relationship, right, that you kept the relationship attached to one seniors residence or nursing home. And I think that's been, shown that they've been far more effective than what we've had in this province. Actually, we still don't have these agreements. So there's a lot of talk about it. And now it's been dragging on for months and months and months. And I think that has to be, for me, it's a major concern that we've still not been able to get that kind of agreements in place in the current context.
Okay. All right. Thank you all so much. This was fascinating and important and really just wonderful. And I especially appreciate how there were some consistent themes across what each of you shared. So thank you. Right now, we're nearing the end of our time together. And so I'd like to ask all of the participants, all of you listening, I'd like to ask you to do something again. And I have another poll. And the question this time is, now, after everything you've heard this morning, how involved in long-term culture change would you like to be? Would you like to be informed about the change taking place? Would you like to be consulted about the changes needed? Would you like to collaborate in making change happen? Would you like to be a leader in the culture change process? And our intention is not to chase you down and hold you to your answer, but we want to get a feel for the interest there is in being involved and to what level. So we just take another 30 seconds, as we did before, to see what your answers are. Okay. Wonderful. So we certainly have broad interest in at least knowing, and it looks like we have some good allies and collaborators. And that's wonderful. It really sounds like we will need to create a wave of change. Wonderful. All right. Thank you for sharing that. And now I wonder if we can go see what Sarah has drawn and invite her to give us a tour of her drawing. Sarah, what have you got for us?
Wow, that was awesome. So much amazing, rich conversation. And as Michelle said, there's so much crossover with all of this that I really just started weaving the three presentations together. So I took what Michelle was talking about in the beginning about planting seeds. And the seeds are really what we're all looking for. And hopefully they will help everything grow in the way that we want it to. So I have family, caring relationships, kindness, compassion, respect, joy, everything that kept on coming out as this conversation was emerging. I also kind of played with the three sisters concept that Michelle introduced in the beginning, where we have the corn and the peas and the squash, and they're all living in this ecosystem together. So they live off of each other, and they're also supporting each other. And so I had Patrick's on the top of the corn, which is the kind of the architecture of the whole thing. And Barb's on the bottom, Barb's in the middle. No, Pat's in the middle, sorry, everybody. Where we're talking about the kind of the people part and what's kind of making it all happen. And Barb is really that part, you know, it's that touchy-feely part. It's what we need to bring into the whole system to make it work, that we're talking about people. Care is a relationship. For me, this was key, and that's why I put it in the middle. Big, I mean, that's what we're talking about. We're caring about people. So in doing that, we have to change the whole system, and not, as Patrick said, it's not about institutionalizing it. It's actually deinstitutionalizing it and focusing on the needs, on the social needs, and having maybe the policymakers actually looking at the people and starting from the ground up, as Michelle said, starting from the ground up instead of from the top down. So I'm going to keep on working on this. I'm hoping to, well, I'll have it done by the end of the day. And I hope that I've reflected what the speakers were talking about, as well as I've tried to bring in what you all shared with us of your dreams of what you hope to see in the future. And, you know, as Michelle said, this is an ongoing conversation, and we're just starting now. So I really look forward to making a better system in Quebec, so that as we all age, we can also feel that we have something to look forward to instead of be scared of. Thank you so much, everyone, and I look forward to the rest of the day.
Thank you, Sarah. I love it. Can't wait to see it take even more shape. And Sarah is going to stay with us in the small group discussions after the main session as well. So she'll be able to weave even more of your perspectives in. The next thing we'd like to do just before we finish is we have a recorded message from the Quebec minister who is responsible for seniors and informal caregivers. This is Minister Marguerite Blais, who was first elected to the National Assembly in 2007. She has experience as a caregiver, and she's a grandmother of 11. And I want to tell you that the beginning of her message is in French, and then she moves into English. We're not able to provide translation of the French, but hang in there. She does get to English.
Bonjour à tous. Avant de poursuivre en anglais, sachez que je suis très heureuse de vous adresser quelques mots ce matin en ouverture de ce sommet qui va vous permettre d'échanger sur le changement de culture qui concerne l'hébergement et les soins de longue durée. C'est une priorité pour moi, je suis revenue en politique aussi à cause de ça, et pour notre gouvernement. La pandémie que nous vivons actuellement nous démontre clairement l'urgence d'agir pour mieux prendre soin de nos aînés et particulièrement ceux qui sont en perte d'autonomie. Mais je rappelle qu'avant même que la COVID-19 vienne nous surprendre, nous avions déjà entamé notre démarche pour mieux prendre soin des personnes hébergées dans les différents milieux de vie. Car nous devons admettre que la pandémie ne justifie pas à elle seule ce qui s'est passé. La crise a exacerbé les problèmes antérieurs présents dans notre système de santé. Toutes les personnes hébergées méritent de recevoir les soins et les services dont elles ont besoin dans le respect et la dignité, et surtout en toute sécurité. Nous souhaitons que les personnes qui ont besoin d'hébergement et de soins de longue durée puissent vivre dans un milieu à dimension humaine qui se rapproche le plus possible d'un domicile. Over the last few months, our government has accelerated the transformation of facilities for seniors and people with special needs, announcing initiatives that include seniors' residence and alternative housing. Other initiatives will be announced in the coming weeks and months. This constitutes a vast project and a shining example of our government's forward-looking vision. This is what we want to collectively accomplish for seniors and, in fact, for everyone that lives in a care facility. This is a new standard of quality that will greatly improve the daily lives of residents and their loved ones. We will also shortly unveil the first policy on seniors and long-term care facilities in the history of Quebec. The policy will be implemented through an action plan, materializing its guidelines by means and concrete measures. This is how we are planning to establish a model of long-term care facilities for the future, one that is more modern in scope and meaning and better adapted to the needs of residents. Long-term care is also the only viable solution when an individual's physical and or cognitive health is such that living at home is no longer an option. Allow me to repeat that we are working tirelessly to implement a long-term care vision for them and their loved ones that will provide welcoming, friendly, familiar, and safe environments to seniors and their family. I want to thank you for taking the time today to discuss these important issues among ourselves, and also thank all the panelists for sharing their experience and expertise. Merci de prendre le temps aujourd'hui de discuter de ces enjeux importants et merci aux différents intervenants de partager leur expertise et leur expérience. I wish you all a productive summit. Bon sommet.
All right, we are coming to the end of a rich and full and fabulous summit. I want to thank you all for your time, your attention, your care, and your contributions. The research is clear at all three of the levels we discussed today. The vision is coming into view and it's promising and exciting, and it's clear that there is a huge amount of work to do. Some of you will stay with us and continue into small group discussions. But to close this portion of the event, I want to just reiterate what's going to come next after the summit. There is a report and a set of recommendations that will be developed and delivered to the provincial government. And we'll share that report with everyone who participated today as well. And you'll also get a survey to evaluate the event with an invitation to participate in future events or in a working group so that we can move things along towards that vision of the future that we've started to imagine together. So as you leave, I would invite you please to write in the chat any highlights of what you're leaving with and further wishes. So let us know what you're leaving with. And for those who are joining the small group discussions, we're going to take a 15-minute break. And then I believe that we can provide the links once again. You should have received them by email, but there should be a link to one of two Zoom calls. So there's one in English and one in French. So join the one that you like. Meet us there at 11:45, please. I will be leading the English session, and a woman named Talitha will lead the French. She's a culture change consultant and professional coach. And during the break, we'll be showing a slideshow of art from Artists for Long-Term Care. So enjoy that. And I hope you all have a wonderful day. Thank you again. We will be in touch.